Welcome, everyone. Thank you for joining us today to learn more about the funding opportunity with the Team Upscaling and Sustainability Center. We know that we'll have some additional folks continuing to join us, but for the sake of time, we're going to get started today. We have a diverse group of participants from across the state. This includes community health centers, clinical teams, and organizational leaders, and we're really excited to have everyone here with us today. Today's session will give you an understanding of the Team Up model, the goals and structure of this RFA, and the supports available to participating practices. Sonia, can we advance the slides? All right, so our agenda, we'll start with an introduction to the Team Up Center's mission, approach, and the core components of the Team Up model. We'll walk through the key elements of the opportunity outlined in the RFA. This will include eligibility, expectations, timeline, and available support for interested practices. We're fortunate to be joined by two leaders from Team Up Legacy Practices. They will share their reflections on their experience partnering with the Team Up Center. So you'll hear from Dr. Amelia Fisher, Director of Pediatrics at South Boston Community Health Center, and Kira Armajani, Project Manager for Pediatric Behavioral Health Integration at the Dimmock Center. We're going to reserve some space for Q&A towards the end of the webinar today. You should be able to include any questions through the Q&A throughout the session. We've enabled that for folks, so please feel free to add in questions there. When we get to the dedicated Q&A section, we will go through those questions and try to address as many of them as possible. All questions, including any that we don't get to today, will be added to our FAQ on the website and shared with registrants following today's webinar. So we will make sure to get back to everyone on the questions that are submitted today in some form. And we will close out the session with just a review of next steps for any practices that are considering an application. So next, I will introduce some of the team members that you'll hear from today. We have Sonia Ehrlich, who oversees workforce development and clinical training initiatives, focusing on creating meaningful, accessible interventions and supporting compassionate, culturally responsive care. Chris Sheldrick oversees evaluation and data activities for the initiative, focusing on building practical, meaningful measurement strategies and supporting practices in using data to guide implementation, improve care, and contribute to a stronger evidence base for pediatric integrated behavioral health. Emily Feinberg oversees strategic growth and partnerships with a focus on advancing the Team Up Center's reach to new states and systems of care. I am Charlotte Vieira. I'm the Deputy Director for Implementation and support practices partnering with us through their integrated care transformation and sustainability. We also have Sonia Nguyen and Peggy Bobo on our team here today, providing support for today's session. And with that, I will hand off to Sonia to talk a little bit more about the Team Up Center and the model.
Thanks, Charlotte. So I'm going to spend a few minutes today providing a brief overview of the Team Up Center, our work, and how this request for applications fits into that work. As you can see on the timeline, Team Up began about 10 years ago in 2015, collaborating with 3 community health centers to co-develop and implement a full spectrum model for integrated behavioral health care within pediatric primary care settings. In 2019, we began a second phase of work where we began a new collaboration with an additional 4 community health centers to spread the model to these new practices and further develop components of the model. The model is now the standard of care in 7 pediatric practices serving over 40,000 children. Last year, we began a third phase of work aimed at scaling the model across the Commonwealth with the goal of expanding to reach 126,000 children in 29 clinics across Massachusetts. While the model was intentionally developed in collaboration with federally qualified health centers when we started, it is also flexible enough to suit a variety of local practice settings. So the current opportunity in 2025, was our first invitation for eligible Massachusetts-based primary care practices to partner with the Team Up Scaling and Sustainability Center to implement the Team Up model. And that leads us here. The Team Up Center's work is organized into 3 main areas that together support meaningful and sustainable integrated behavioral health care in pediatric primary care. First, transforming care. We help practices implement the Team Up model by building strong care teams, integrating behavioral health into everyday clinical workflows, and improving access for children and families. Our care pathway begins with routine behavioral health screening during well-child visits. When a concern is identified, the behavioral health clinician or community health worker meets with the family through a warm handoff to assess needs and offer support. This team provides brief interventions, care coordination, and referrals as needed. The goal is timely, family-centered, and culturally responsive care delivered right in people's medical homes. So second, we have data evaluation and research. We support practices in using data to understand their care processes and improve their outcomes. We also evaluate how the model works in practice and contribute to the broader evidence base for pediatric integrated behavioral health. Third, we have advocacy and systems change. We work toward long-term sustainability of integrated behavioral health care through workforce development and advocacy efforts. In partnership with Healthcare for All, we help inform policymakers about the impact of this model. All of these efforts together have produced strong results. Many studies show that Team Up increases behavioral health screening with more than 90% of well-child visits, including screening. Children are often connected to same-day on-site support. Outcomes improve, including better quality of life and school attendance. Providers experience reduced burnout, and practices see stronger engagement in primary care without increases in total cost of care. Thank you. So our legacy sites have been essential partners in shaping the Team Up model. Many are federally qualified health centers that serve diverse communities, and their early work helped us understand what it takes to integrate behavioral health meaningfully into pediatric primary care. Their experience informed the development of our training, our workflows, and our data support. We have since expanded our partnerships to include additional practices across Massachusetts, helping us bring the model to scale and demonstrating how Team Up can be implemented in a range of practice environments. We are also extending our work nationally through new partnerships in New York City and Georgia, further demonstrating how the model can be adapted to support children and families in diverse settings. As you can see on this map, we are extending the work nationally. And in addition to our work in Massachusetts, we recently finished an engagement in Rhode Island. And we have currently established new partnerships in New York City and Georgia, as I mentioned. So now we're excited to be joined by Dr. Fisher, who is the Director of Pediatrics at South Boston Community Health Center. Welcome, Dr. Amelia Fisher. She is a pediatrician and Director of Pediatrics at South Boston Community Health Center, where she has been practicing for the last 8 years. She participated in the Team Up partnership in Cohort 2 at her health center. So today she's going to talk a little bit about what their clinical practice looked like before Team Up, what it was like to go through the transformation process, what it required, and where they were able to draw upon support, and what made the partnership meaningful. Thank you for being here, Dr. Fisher.
Thanks for having me. Can you hear me okay?
Yeah.
Okay, great. Um, so I'll go over some sort of highlights. I won't be able to I guess I'll talk about everything because there's a lot of things um, that Team Up helped us with. But before Team Up, just as a snapshot, we had one case manager for the entire health center. We didn't have any dedicated pediatric social workers. We didn't have a formal warm handoff procedure, and our internal referrals for counseling was a very long list that was resulting in delays in care. And in terms of the going through the team up process, I think that the things that made it successful were that we had buy-in administratively, and we had people who were champions of the model internally and were working to implement the changes. It does take time, so it does take administrative time. Um, and um, and and I think that probably one of the biggest impacts, though, was that we got the funding support for this time and for doing the integrated work. So we were able to show sort of feedback to the health center and the health center administration that these sort of positions and roles and training was all something that was really valuable and not and something that was worth continuing to support even when the team up funding went away. So I think that's been the real legacy of Team Up is that we've continued to do um, a number of a number of different um, a number of different ways in which behavioral health has been integrated that we've actually been able to continue because we were able to show how valuable it was with help from the funding from Team Up. And so in terms of what we have now, so we have two community health workers who do a lot of our warm handoffs and are able to do assess for various needs and make various referrals. We also have behavioral health clinicians who are doing the warm handoffs when there's a clinical concern or clinical need. And both of those sets of folks have pediatric specific knowledge and training through Team Up, which has been really helpful. Similarly, we have multiple social workers who are seeing kids and have experience in seeing kids and doing therapy and counseling with kids and families. We have a well-oiled warm handoff system that's used across departments. And we also have monthly meetings where we check the clinical directors, check in with the community health workers to see how the warm handoff process is working. So we're constantly looking for ways in which we can improve it. We've moved away from doing internal referrals for counseling, and we actually use our warm handoffs and a behavioral health desktop. So patients are getting into we don't have this backlog of referrals anymore, which is amazing. And patients are being linked to care in a much quicker fashion. And then another thing just to highlight as a pediatrician is during Team Up, we had consultation with pediatric psychiatry for clinical questions, case consultations, and that's something that's continued and it's been a huge resource for us. So there's a BMC pediatric psychiatrist that we've been meeting with monthly that has basically open time for us to run any cases by her. So that's been another thing that started during Team Up and that fortunately has continued. So those are just a few things related to our Team Up experience.
Thanks so much, Dr. Fisher. We know you're in the middle of your clinic day, so we really appreciate you taking the time to share about your experience. I'm going to pass it to Charlotte now.
Thanks, Sonia. And thank you, Dr. Fisher. So we're going to talk a little bit about the RFA opportunity now. This RFA is an opportunity for practices to join a cohort to implement the team up model. It's a 30-month initiative during which practices will receive comprehensive financial, technical, and operational support. I'll have you jump to the next slide, Sonia, and we will review eligibility requirements. So the opportunity is for pediatric and family medicine practices that serve children and adolescents in Massachusetts. Practices must demonstrate a commitment to supporting integration of the model with a staffing ratio of one full-time behavioral health clinician and one full-time community health worker per 3,000 patients. So practices with fewer than 3,000 patients would still commit to this minimum of one FTE for each role, and then that staffing ratio would scale as the patient population increased for the practice. Because this is a multi-year initiative, practices are really discouraged from having any major transitions in the future that they're able to anticipate. So things like leadership changes, mergers, or significant EHR replacements or upgrades. And finally, sites must be prepared to engage fully in the different activities. So this includes training, practice transformation, and evaluation activities, all of which we'll talk about in more detail today, and then are also available as part of the appendices of the RFA for a full outline of those components. So to speak to the implementation process, practices implement the model in three phases. There is an initial onboarding that would take place from February to March in our timeline. This is of the 2026 calendar year. And during this time, we complete onboarding activities, finalize contracts, and begin initial coordination with each practice's team. The first phase of the initiative is focused on implementation planning. This runs from April through September of 2026. This is a period when practices are working to build the infrastructure that's necessary to support the integrated behavioral health model. The second phase is active implementation from October 2026 through March 2028. This is the most intensive period of the initiative. We're focused on regular training and practice transformation activities to engage all levels of the organization and providing ongoing technical assistance to build and sustain that integrated team and the different workflows that are part of the team up model. The final phase is focused on sustainability. This is from April through September of 2028. In this phase, practices are working to solidify sustainability plans and prepare for certification in the team up model. And across all of these phases, practices are receiving structured support that's really tailored towards their specific needs and context. The goal of this work, as you heard from Dr. Fisher, is really to make sure that what we're putting together for practices that participate with us is sustainable, and that you end this initiative with an effective model of integrated behavioral health in your pediatric primary care that works for your practice and your patient population. So throughout these phases, practices are focused on building the integrated team. This is in alignment with that staffing ratio that was shared previously. We're engaging in training to support workforce development and working to establish those different workflows that are necessary to adopting this type of team-based approach. And throughout this work, we are working with the evaluation team to engage practices in evaluation activities, which you'll hear more about shortly. The learning community is the central hub for the training, technical assistance, and peer exchange that we offer and facilitate throughout the initiative. Because we know that change is more sustainable when there are just more people involved and invested in the work, We do ask members of both the clinical and administrative teams to participate in different activities through this learning community. These include role-specific trainings and clinical consultation calls, as well as asynchronous learning modules that we make available. We have practice transformation meetings that provide site-specific technical assistance and support through the initiative. And we have a series of cross-practice workshops that support leadership development, revenue and operations, and allow for that peer exchange between practices that are participating together in the cohort. And again, all of these activities, there is a full outline of them in the appendices of the RFA for practices that want to kind of get into the details of what this entails. Um, Finally, just thinking about kind of the setup and what the engagement looks like, we ask practices to designate an administrative leadership team that's really guiding the implementation effort within the practice. This includes an executive sponsor from senior leadership who can champion the initiative, ensure that there's alignment, and then support that long-term sustainability. We look for clinical champions in both primary care and behavioral health to lead the day-to-day, as well as a project manager and IT and billing leads that are there to support the development of the operational infrastructure. Practices also develop and engage a multidisciplinary integrated care team, and this includes primary care providers, behavioral health clinicians, and community health workers. And they are regularly engaged through the learning community as well as the leadership team to support ensuring that there really is a transformative process with all of these members engaged together in the initiative. So I'm at this point, I'm going to hand off to Chris to talk a little bit more about the evaluation and what data management looks like for the initiative. Chris, you are on mute.
There we go. And I'm supposed to be the technical guy. There we go. Anyway, just a few brief comments about data management and evaluation. So using data wisely is central to implementing and sustaining the team up model. So we do our best to support practices to use data all the way throughout the initiative to guide the transformation work, to monitor progress, and to understand their impact. So we recognize too that practices are coming from very different places and it can vary a lot in their data capacity. So we make sure that each site has the support that they need to use data effectively for quality improvement and for day-to-day implementation decisions. We really want to make this practical and usable for the sites. So as part of the initiative, practices also participate in a structured evaluation that's designed to help us understand how the team-up model is being implemented and what outcomes it's achieving. So we'll walk through the components of that evaluation a little bit in the next slide. So a really core part of implementing the team-up model is making sure that the electronic health record systems are set up to capture the right information. So we work closely with each site to support the build and placement of screening tools, of documentation templates, and of workflows, both to support clinical care, but also to support QI, and then ultimately to stream down to evaluation as well. We offer flexible options for achieving that. So for example, for extracting data from the EHR and for creating dashboards, one option is to work with our strategic partner, a company called Relevant Healthcare, that works well across a range of technical environments. But if Relevant Healthcare is not the right fit for your particular practice, we'll work together to identify an alternative approach that still supports the data needs of the initiative and helps you to succeed. So to make this work, however, one common denominator is that dedicated data and IT capacity is really, really important. So we ask practices to identify staff who can help to configure the EHR, support documentation workflows, and help to manage that data extraction and reporting. So we'll work with these folks closely to make sure that all the different needs are met. Now, in addition to EHR data, the evaluation also draws on staff surveys, which obviously we would be looking to the different sites for, and on statewide claims data. Now, that doesn't require any effort or place any burden on the sites themselves, but provides very, very valuable data for evaluation. These additional sources help us build a more complete picture of implementation and of outcomes, and I'll say a little bit more about that on the next slide. So again, evaluation is a core part of the initiative. Each practice contributes data that helps us understand how the model is being implemented and the impact it's having on children, on their families, and importantly, on the care teams themselves. All evaluation activities follow IRB approved protocols. So we at the Team Up Center manage the IRB processes. So practices don't need to take this on themselves, although we'll be, again, looking for your support to make sure all the different approvals are in place. We also ask each site to designate someone to serve as the research committee representative. This person will work on the committee to help review data use requests, to stay updated on dissemination activities, and to act as the practice's main point of contact for evaluation questions. So this is like one of the many processes that we have in place, really to make sure that the data that we have are used well and wisely, and help to support the Team Up initiative as a whole, but also your site in particular. Participation includes, as I mentioned, several types of data contributions. The EHR-based data are core. The staff surveys, I will just say, are really important about professional well-being, and they're very, very brief. And as I mentioned, the statewide claims data analysis. So together, these sources of data really help us to provide a full picture that's helped us advance over time. These contributions, a really critical part of these data, I will just emphasize, is it's really about continuous quality improvement within each practice, but also secondarily, we can use them to support the broader evidence base around pediatric integrated behavioral health care as it expands around the field. And with that, I will hand off to Charlotte.
Thank you, Chris. So we're going to be moving into another practice spotlight to hear from another one of our past partners. I believe we're a little ahead of schedule, and so we might just be waiting on her to arrive. We do have a question in the Q&A though, and so maybe we'll take this opportunity to answer that. So the question is, how much time do you estimate will be required for each member of the implementation team? How does that change through the different phases of the project? We actually have in the appendices of the RFA, there is a table that outlines the different roles that we talked about and does provide a time estimate for each of the roles. And so that can give you a sense. That really is looking at the time investment for the different activities that we're asking people to participate in. I would say that there is an additional time that, as Dr. Fisher mentioned, in order to move this work forward internally, there'll be some additional time spent on that. But it gives a good sense of how the activities kind of build over the full 30 months. I will say that for some of the members in the leadership team, the activities run the full 30 months, but that clinical team is really most engaged in that active implementation period, which is 18 months long. And Sonia, I don't know if you want to say anything more about that, just with the trainings that we run for clinical staff.
Yeah, I think the initial sort of planning phase is really focused on the project leadership, and the kind of administrative roles are doing the bulk of the activities there and building the integrated care team. And then, as Charlotte said, the direct care providers, the clinical care team, will really be engaged in the most training and practice transformation activities throughout that active implementation period. And then during the sustainability period, that's an opportunity for folks to make up things that they hadn't been able to do, or if there is staff turnover or if the practice has onboarded new staff, that's another opportunity for people to do what needs to be done. And I think Kira's here now.
Excellent. All right, so we will now turn to welcoming our next guest speaker. Kira Armajani is the project manager for pediatric behavioral health integration at the Dimick Center. She has been working in community health for the past 13 years and has spent 9 of those years at Dimick. And she served as a behavioral health champion in one of our past implementation initiatives. And so, similar to Dr. Fisher, we've asked Kira to talk a little bit about what clinical practice looked like prior to Team Up, and then what that transformation process looked like, what supports the team drew on, and kind of what was most meaningful. Kira, welcome. We're really glad to have you with us, and I'll turn it over to you.
Great, thank you. No. Am I on? Sorry, I can't see. Okay.
Yes. Yep.
Sorry. The view is different over here. Yeah, so I joined, I came to Dimick right around the time as Team Up was starting. So it's a little hard for me to discuss kind of pre-Team Up life at Dimick, what that looked like. They had just started the integration process, and we were fully in the Team Up mode. I think, seeing it from the start, and now obviously we've been out for the other side of Team Up for a few years now. So I think, kind of what did it require? I think obviously a lot of buy-in from administration, and, the whole team being, from pediatricians to the nurses, and also to the clinicians, willing to do this work. I think it also, with Team Up, we expanded some of our scope to, seeing younger kids, or doing more parental referrals, incorporating our OB team. And so I think some of the trainings that we were able to do with Team Up were really helpful in our staff feeling comfortable doing that work, with, populations that we might not have been as comfortable with in the past, like under 5 years old, for example, was really helpful. The support we got from the Team Up teams. I think those trainings were really helpful in creating that space for us. I think also just like flexibility, being able to adapt, trying things, and going back to the drawing board and kind of see how can we rework this. I think, especially in those early years of kind of figuring out, what's going to work for us. I think of like our parental referrals with the OB team, and like how that's evolved a lot over the years, through Team Up and then beyond, was a big thing, as well as again those younger referrals. I think where you said where you draw support, can I think really with integration model, like you got to have the support of your team, and again that goes from like the front desk worker all the way back. So I think we were really lucky in our pediatric department to have a really close team, to be able to make this work, and for providers to feel comfortable coming and grabbing us, for a warm handoff, or even just ask a question like, is this appropriate, or kind of what do I do with this? So I think, having that team support is definitely number one. And then I think, again, like I said, with the training stuff, like having the Team Up community, to, as I know in those early years, like we had I don't remember what they're called now, but we kind of like the case presentations, from the different health centers, which was really, I think, helpful to connect with the other people in the cohort to see kind of how they're doing things and how could we shift things, where are the challenges that we're all experiencing, and kind of how can we leverage support from the Team Up community. And again, past our grant with Team Up, still been in communication when things have come up, especially around like trying to advocate for better reimbursement rates or stuff with like things like that. So I think the Team Up community has been really just a great support through it. And then again, being able to still have this connection to you guys has been really wonderful. The last part of that was what made it meaningful. So I think, number one is, patient outcomes. Like we know integrated care, we see people get better faster and more sustainable long-term. And I think that also, community health, we're seeing some really hard cases. And I think, when you have that support, you're not holding the case solely by yourself. You have the pediatrician involved, you have the psychiatrist or the community health worker. I think it just spreads a little bit of that stress. And I think we've definitely seen in our team, I think, less burnout. We've been really fortunate to have a really cohesive team. I think we've had many staff for many years. We haven't had a ton of turnover. So I think that that's, really honestly integral to the integrated model. So I think for both patients and staff, it's just a really wonderful kind of setup.
Thank you, Kara. Really appreciate you joining us today and sharing that experience, and where your team is now, knowing that you were, as you said, Dimick Center was part of our first cohort, and you've been able to sustain and continue to engage with us has been wonderful. So thank you so much for being here.
Of course, thank you.
Yeah. We are going to turn over to our Q&A section. So Sonia, I will pass it back to you for that.
Thanks. Yeah, so do feel free to add to the Q&A, or if you want to ask your question verbally, just raise your hand and we'll call on you. There is a question in the chat from Manju Chopra. Does a mental health specialist need to be part of the application? Our practice has a psychologist come in a few days a week, but not sure how she would need to be involved for this. That's a great question. I guess the short answer is that person doesn't necessarily need to be part of the application process. Of course, if you are part of Team Up, you need to have at a certain point, you need to get your staffing to the ratios that we're asking. So you would need to have a full-time behavioral health clinician for every 3,000 pediatric patients. So that person doesn't necessarily need to be part of the application process. Many people build their team once they've already applied and become part of it. So I don't know, Charlotte, do you want to expand upon that?
The only other thing that I might add is that we do, when we talked about kind of the leadership team that we ask practices to establish, we do include a role for a champion who is more focused in the behavioral health work. And so this could be a behavioral health manager, director. It could be just a behavioral health clinician who is very passionate about the work and able to support some of the leadership of the initiative. And so I think that there would just be a question about is this individual somebody who might be a good fit for that role, or is there someone else that would support that role? But we have worked with a range of practices, some of whom had very little to no existing behavioral health. So again, as Sonia said, I think some of these details we could certainly work out with sites as they're thinking about an application, or once joined the cohort, kind of thinking about putting together the right team. So it sounds like you have a good resource in this individual, and yet you don't have to commit them to anything at this point to be able to move forward.
Thanks. Are there other questions out there? Just to note, we also, it can be a lot to digest. So as you go through the application and the documents and the appendices, questions may arise, and we are available to for one-on-one support as things come up. Okay. Well, wow, we are way ahead of schedule, so people are going to get a bunch of time back, but want to highlight some key dates. First of all, as I mentioned, for technical assistance or questions or clarifications, please reach out to recruitment.teamupcenter@bmc.org. and we should get back to you within 24 hours during the weekdays. The application deadline is Friday, December 12th at 5 p.m. The selection notification will happen on January 30th of next year. The onboarding will begin in February and will go for about a month, last for February and March, and then we'll launch the next cohort in April of 2026. So those are some dates to look forward to.
So
Really
yeah, I
glad.
might say one thing that has come up as a question um, from sites is that there are sometimes practices that are interested in applying that are part of a larger organization. And so there might be multiple practices within a larger organization interested in the opportunity. Um, if that is the case for anybody here who's considering an application, we would ideally ask sites to apply at the practice level. But we can also, as Sonia has said, we can also have a brief conversation with your organization individually to think about, how things are structured and what the best way to put in that application would be. But that is something that has come up in the past with previous RFAs, and so wanted to just note that as well as folks are thinking about how to move forward.
Yeah. And there's a lot of paperwork, but the application doesn't actually take too long. We've been pretty deliberate about that. So yeah, let us know if you have questions. Thank you so much for taking the time to join us today. Looking forward to potentially getting to know some of you all in the future.